Esophageal atresia is not a new problem. It's a congenital problem. It's been around forever. And here's a little, the first report of esophageal atresia in 1696, when Dr. Gibson was called to see a baby who kept choking and sputtering and eventually died from the inability to swallow and aspirate. So early on, esophageal atresia and any esophageal condition was essentially fatal for a number of reasons. And mostly because you couldn't even get into the chest. I just want to give a sort of a perspective of how far we've come, how fast. Remember, we couldn't do chest surgery in the 1800s. If you opened the thorax, the lungs would collapse and the patients would just die. So that wasn't really understood. The only thing they could really do was do sort of an extra thoracic bypass of any problems. For things called skin tube, they just roll up a big piece of skin and use a skin tube as the way to bypass an esophageal problem. And this is just an illustration of a child. Effective, but not perfectly effective. Slowly, anesthesia sort of caught along, and there was this research where the surgeon would operate in a chamber that had varying pressures while the patient's head was outside of the room. Talk about weird, having your ears constantly popping. And then they decided we could actually ventilate the patient. Here's an early illustration of an anesthesiologist. You had a box on the child's head, or the patient's head, and the air pressure would vary inside in this box, and would force the air in and out of the airway, so the surgeon could operate without being in this box. So the slow progress was being made, and when they had eventually able to control the airway and ventilation, then they could operate on the intrathoracic esophagus. And this is sort of the early solution, was the rubber tube. Go in there, you take out the esophageal cancer, and you put a rubber tube from the neck into the stomach. I'm sure it worked for saliva, but not much else. But there's some progress, and that was only in the early 1900s. We're talking less than, or about 100 years ago, right? And endotracheal tubes came along, and eventually double lumen endotracheal tubes. And now we could actually do major surgery in the thorax, and gastric tubes and things like that came along. So we finally had some progress. It wasn't until 1939, what, 70 some odd years ago, that the first esophageal atresia was repaired, I'm proud to say in Boston Children's, with a skin tube, which had been developed earlier than that. And it was simply a multi-stage operation to reestablish some esophageal continuity. Millie actually lived, she may be alive now, she had cancer in her skin tube in her 30s and had colon esophagus. Dr. Haight in Michigan was the first one to actually repair an esophagus in the 1940s, right around World War II, when thoracic surgery was really starting to take off. So esophageal atresia is a complicated problem. There's little simple ones for us now in the last 67 years. It's not a big deal. We can fix it. If it's a short gap, if it's a longer gap, it's more of a challenge. And this is a, many surgeons are terrified when they get this call if they have a child with esophageal atresia, can't get the NG tube to pass, and there's a gasless abdomen, and you just go, oh my God, what next? Because you're up for a challenge. This is not going to be simple. And so it's important to start with what are our goals? Because we are taking on a hard problem with this kid. And our goals are first to keep the child as healthy as possible. We want to keep good nutrition. We see nutritional deficiencies all the time, even in the US. You got to get nutrified, keep them from getting infected, and keep them well oxygenated. We also need to understand their problems, because a lot of these kids, 40–50%, have the VAC-dural association. We don't know what that is, I won't go into it, but they have all these other problems. So our job is to understand the problems and then sort of stratify our treatments. Then we want to improve the disability. What is the disability? What is going to hurt this child? Often it turns out it's going to be the heart, the trigeminal flow, VSDs, single ventricles, those all come along with these kids. And we want to treat their respiratory problems. They have a lot of respiratory problems. Finally, whatever we do, we want to minimize the risks of our treatment. We don't want to make the child worse by jumping in and trying to treat them, including brain development, because repeated episodes of hypoxia or very poor nutrition leads to developmental disability. And finally, we want to optimize our long-term outcome. And what does that mean? Well, we want to keep good food, we want to keep them growing. We want to have them eat. Hopefully they can eat independently. And that would be great. We all want that for our kids. And finally, really, when you really think about it, what our society wants from us is to turn this disabled child into a productive member of society and pay taxes. That's what we really want, right? So that's our goal. So let's talk a little bit about pure esophageal atresia. Well, it's got a blind proximal patch, often has a fistula, maybe a very long gap, and we are going to have a tough time understanding. So let's do a little bronchoscopy. We're going to understand the airway side of it, because they all have airway problems. Remember, 30% have laryngeal clefts, 5 or 6% have proximal TDFs, 80% have tracheal malacia. These aren't so simple. And we want to control their problems. We like to evaluate it with a simple contrast setting. We don't shove the bougies up there or metal probes, because often those metal things we put up there go in the wrong place. They push the fundus up and we think it's a short gap and we get more terrified. Or we've seen kids with a gap, you get in the esophagus and they tear it, now you have a septic mediastinitis. Let's just do a simple contrast setting. We can all compare it, and we see what we have. And this is the worst type of the long gap esophageal atresia. That, in fact, is the lower esophagus, and that child was grown up to get a normal esophagus in the end. So I would advocate just a contrast setting. And I would advocate the surgeon does it himself or with radiology guidance, so that you actually do understand the lower esophagus. Because these kids have a lot of problems in the lower esophagus. We recently had a kid with 2 atresias. We thought he was a not so long gap, and it would be pretty long gap. There's 2. They often have congenital strictures. A couple of % have congenital strictures. So we want to understand the problem. Then we understand what we have left to work with. If this, that's pretty simple. If we have this and a little fistula, we can deal with that. Remember, we close this fistula linearly, not transversely. Now we have this, that's not so bad. This is a bad problem. All can be solved in some fashion. So what are our goals? Well, we want to close that gap. We minimize the gap between the 2 ends to get them closer together. We can do that by bringing the lower end up, the upper end down, get them closer, and then sometimes you have to do other stuff. You have to fill the gap. One of the old techniques is a circular myotomy. You cut the muscle all the way around, you're leaving the mucosa intact. Mucosa is kind of stretchy. You can sort of get a little bit more. If you just need a little bit, you can get that. The problem is the blood flow is right in this muscle. It's really taking the blood flow away, most of it, but not all of it, from this segment. So you end up with sort of a relatively ischemic segment. But you do get a little length. I'm not advocating against it, I'm just understanding the risks. So you increase the incidence of strictures, increase incidence of leaks, and you get a big dilated segment above it. But if it allows you to get an anastomosis, and that's what you need to do, then you can do it. But you may end up with this problem. This child had a stricture, got dilated, eventually ended up with this big capacitor here. Here's another dilated, stricture was dilated, had this big segment, and we're going to have to go to fix him pretty soon. That's not so easy, because that problem is always close to the thoracic inlet. So what's another thing you can do? Another thing you can do is move the stomach up. If you're in the chest and you just need a centimeter, just enough to get it together, then go down to the esophageal hiatus in the diaphragm, you're in the chest, just go down there, loosen things up, pull, and the stomach's going to come up a little bit. It's going to come up, give you a centimeter or 2 centimeters pretty easily. You don't even have to go into the abdomen. You are in the abdomen, but you're in the chest to do that. Or you can pull the whole stomach all the way up, and that takes a laparotomy and mobilization of the vessels. The good thing about that, the stomach's sort of hard to kill, but if you're going to bring the stomach all the way up, you can end up transecting the vagus nerves. You can get gastroparesis to do ponderoplasty. So how do we do this operation? Well, if you're going to do a total gastric pull-up, the traditional way is through the left chest. This kid may have a spit fistula or not, depends on what you were doing at the time. And then you go through a abdominal approach, mobilize the stomach. Typically, you would take off the lower esophagus, which is disappointing to me because you could use that to grow the whole thing, but it happens. Save the gastrocolic artery, base it on here, bring it up to the diaphragm, bring it up to the chest, up to the neck, and this is what you got. Unfortunately, in our experience, what we see, because we're referral center, we only see complications, we see this big dilated stomach in the chest, which is taking up a lot of the room for the lungs and decreases the ability of the child to breathe. But everything else is fine. You get a little stasis here, poor gastric emptying, get overgrowth. And that is one of the problems, is this big dilated segment of stomach in the left chest, if you do that approach. One of the solutions people advocate is bringing it to the posterior mediastinum. I'm not sure how many surgeons have the skills to go inside the aorta and all that, but if you have that skill, it will, by having it in the mediastinum, it decreases the forces of distension of the stomach. So if you look at the outcomes, this is Dr. Spitz, who's sort of the guy for gastric pull-ups. And most of these children are malnourished, they have low iron stores and anemic, a lot of them have dumping, and most importantly for me, a lot of them have respiratory compromise. So that's not a fabulous outcome, but the good news is the child's up, eating, and relatively independent. So that's good. So technically easy, adequate length, you have excellent blood supply. It's really hard to kill, although the upper end often gets ischemic and causes some strictures. You can do this through the telescope, if you're skilled with the telescope. That's an advantage, because it's hard to kill the stomach. The disadvantage is all we talked about: poor pulmonary function, a lot of reflux, aspiration, late cancer, late formation of cancer, where you have chronic aspiration and irritation of the cervical esophagus, and all this anemia problems. So there's some solutions to that. If this is the problem, why don't we do gastric tubes? Gastric tubes are fabulous. Just based on one of the vascular supplies, and you just bring the tube up, you can do these three different types. This is what they look like sort of in a drawing. You have the vascular pedicle running up alongside of the side of it. You can have it, but remember, this isn't really peristaltic anymore. But interestingly enough, the stomach does maintain tone and it does contract. It's just not peristaltic contraction. It's sort of tension contractions. And you have to make sure you provide some gastric outlet, because you almost undoubtedly divide the vagus nerves doing this. But the problem here is the suture line. You have this really long suture line. And there have been reports of these eroding into the lung, the airway, pericardium. Not necessarily great things to have happen, but you don't have that giant conduit sitting in the chest compromising pulmonary function. This is pretty long. You can bring it all the way up to the neck, and in this case of a spit fistula, you can sort of sew to the spit fistula and drop it back into the neck. You actually have a pretty good length there. Once again, if you're really skilled, you can bring it inside the mediastinum, where it won't be so affected by the negative forces of the portal space. But this is the long-term outcome of the gastric tube. And this is just these diverticuli that have formed, effectively causing complete obstruction. This is actually the gastric tube. This is a diverticulum, and a diverticulum, and a diverticulum. We couldn't find the lumen. And so this had to be replaced. Remember, these had the stomach still contracting, and all the little vessels went through the wall of the stomach and formed these diverticulum. So the gastric tube has some advantages over the stomach. It's good length, good blood supply. You don't have to compromise lung function. The disadvantage is long suture line, risks of strictures and leaks in these diverticuli. You still have all the problem with reflux, regurgitation, aspiration, and late formation of cancer in the cervical esophagus. But you did get to work. The child is swallowing, and perhaps the adult surgeon is going to handle when he's older and not a problem. I was really struck by Dr. Oranger, who you may all know is a famous thoracic surgeon in Michigan, who gets a lot of esophageal atresia patients, and he treats them in their 30s and 40s, most of them are type Cs, for carcinoma. He treats them for adenocarcinoma of the lower esophagus and squamous cell carcinoma of the anastomosis. There's about 3% combined incidence of the two. So he's saying, why do your operation first? He doesn't like when people do gastric pull-up and they get cancer in their neck, because he says, then I take out the cancer in the stomach, and what do I replace it with? So there's other options. One is a colon conduit. We love the colon. It is designed to be moved around because it has a beautiful marginal artery, and it's got 3 attachments. So we can use ileocecal, we can use transverse or right, and we can use left part of transverse. It's a great conduit. And it's easy to get all the way up into the neck, and we can do it all the various ways, whether we take out transverse or we take out ileocolic. Some people believe in one or the other. But the thing about the colon, it's completely peristaltic once it's at the abdomen. So it doesn't matter if it's anti-peristaltic or pro-peristaltic, it's just going to sit there. And what happens, it very commonly gets dilated and forms this siphon. In this particular child, we did a colon interposition, and within a year, the child was aspirating constantly. They get a lot of bacterial overgrowth. This looks like the little thing on your sink, the P-trap. The bacteria get first shot at all the nutrition and the vitamins. And it still has problems with ischemia. Typically at the top end, may lead some strictures and problems. And over time, because it's aperistaltic, things can just sit in it. And this is a child, or a young man actually, had his megacolon sitting in his chest that we had to take out. And you can see that it's compromises pulmonary function significantly. So the long-term outcomes of colon positions, they're not bad. I mean, you've got a child who can eat, walks around, has reflux. You can get through the leakage problem and the stricture problem, tend to dilate it, at least in the short term. A lot of them have dysphagia, and a lot of them have problems growing just because it's hard to get to swallow. But you have succeeded. You've got this child who can eat, walk, is fairly independent, and actually become a productive member of society, just sort of a chronically ill problem. So, it's good. It's not the worst thing in the world. 3 anastomosis, slow transit. This is the biggest problem. I tell my patients if they have a colon intervention, about every 10 years, you're probably going to need another operation. And the operation is you do laparotomy, you pull the colon down until it's straight, preserving the vascular supply, and just go back to the stomach. It's not the worst. And you can probably do this with a telescope if you're really good. I'm not that good. We much prefer to do the jejunal position. I had a nice little conversation about this yesterday. It's a very good conduit, and there's multiple options of ways to do it. Connect to the duodenum, connect it to the stomach. We talked about the various decision making. We'll go into that today. It is completely dependent on the arcades. This is a challenging operation from a technical perspective because these arcades are different in every one of us, and we have to understand them to get it to work. And I highly advocate a microvascular anastomosis for the long conduits that go into the neck, just to support it. It's called supercharge. It doesn't look like it needs it at the time you do it, but if you don't do it, you have a higher incidence of strictures and leaks. If you look at some of the reviews that compare a gastric pull-up to a jejunal position without any microvascular anastomosis, the key is no microvascular anastomosis. The jejunal position did worse because of the stricture rate versus the gastric pull-up with a fourth of having strictures. If you look at the long-term follow-up of jejunal positions who had no microvascular support, it's not bad. 1 loss, a graft, we had some late deaths, and 2 strictures. But those who survived ate everything they want. They're doing phenomenal, and there's no further complications. Dr. Volker did a 33-year follow-up for some patients who had jejunal positions as children, and there was a very complicated multi-stage operation in those days. Great outcomes, normal motility, no stenosis, 1 little dilated jejunum. All these kids were eating totally fine and independent. So the advantages is lots of jejunum. You can move things around, it'll reach all the way into the neck. It doesn't dilate up, it doesn't fill the whole chest, doesn't compromise pulmonary function. It maintains peristalsis. Remember I showed that video yesterday, showing the peristalsis even a year out. And there's fewer late complications. But up front, it's a challenging operation. It takes a microvascular anastomosis for the long ones, not for the short ones. It's technically demanding, and it takes a lot of multidisciplinary surgical expertise to pull this off. But it has, in my opinion, the best long-term outcome of all the positions. We always like to think one's own esophagus is best. And you talk to surgeons who treat these kids, and we all agree we want your own esophagus if we could have it. And so we're really talking about solutions to this point within the traditional plumber approach. We move things around, we repair what's there, or we replace them. The biologic approach is a little bit different. That is, try to grow what you have, preserve what you have, and customize that treatment to the individual patient. It makes it a process, not an event. You're not going to move so things good. You're going to have to take time for things to develop. But you have to understand it is actually possible to grow the esophagus inside the human body, so you don't necessarily need to have like transplants and things. You don't have to have stem cells, we just grow what we have. And there's a lot of options. Let's talk about some of the options. But the concept that underlies every one of these options is if you give a mechanical force to the organ, it's going to grow. And we can talk offline, but that's absolutely true. This has been shown in orthopedics with the Elizarov method, where they grow the leg and the bones. You forget they're actually growing muscles and blood vessels and nerves as well. It's been applied to facial distraction. The dentists do it to make your jaw grow. Everybody does this. You can even talk about how to close a giant fallacy by growing the abdominal wall someday. it works. Dr. Hendren at Boston Children's, actually used the MGA to this point, was the first to try magnets. He had magnets, he had a couple of babies with esophageal atresia, put these little magnets on. They were pulsatile magnets because he didn't want to cause any continuous damage. And he put them inside this electromagnetic chamber here. There's the kid, there's a little magnet going through him, and it would just pulse on and off, on and off, on and off. And eventually got several of these kids' esophagus together, and one leaked. One of the magnets went off into the mediastinum, caused a septic mediastinitis, and it was a tough battle. So he lost all of hospital approval for the procedure, and since this time, even though we've tried, the FDA won't approve this kind of a device. There's others, Dr. Zuritsky, who worked in Argentina, I believe, has been able to get some magnets to grow. He had 5 patients. Some of them had fistulas were divided for the upper side, so a little surgery, but the surgeons couldn't get it together. And so he was able to get these type of esophageal anastomoses, even though the surgeons couldn't do it. And then they had some strictures that had to be dealt with. And this is the technique there. These little catheters, one goes in the mouth, one goes through the G-tube, magnets at either end, and slowly advance the magnets together. In 5 or 6 days it gets together. When the magnets come together, it replaces with an NG tube. This is fabulous. This is absolutely fabulous. We did this, and here he's just recently reported something with, I think, 13 patients. Small gaps, drops a magnet in above and below. Magnets provide continuous attention. Eventually the magnets come together, the 2 ends necrose, and then he replaces that with an NG tube, and still has a stricture problem. But we all have stricture problems. It's not a crime. One child had a little sepsis, but this is actually pretty good results. We're totally excited about this, and we've been actually. So many people have been working on magnets for so long. Magnetosis is Mike Harrison's information. We were working on this when I was a fellow 20 years in San Francisco, and eventually came out to do, just to put little magnets and grow things together, including the esophagus. We can do it for whatever you want to do, just to test it, put a coloesophageal anastomosis. You could probably put one in the stomach and one on the skin and make a nice little gastrostomy. Anything you do between 2 magnets is going to necrose and end up with an anastomosis. It's great. We're working with MIT today. We're still working with MIT to try to solve one of the problems with magnets, and that is the closer they get together, the more powerful they are. And if you get them really close together, they snap together and they don't tear anything in between, or they'll just dissect whatever's there. And so this is a very clever trick, which is you have the magnets here, and they're continuous magnets. This senses the oxygenation of the tissue, and whenever the oxygenation gets too low, injects a little fluid between the magnet and the bottom of this catheter. The magnet pulls back, and the tension drops. As soon as the tension drops too much, then it goes back. It's constantly adjusting the distance of this magnet by this column of fluid. Very cool trick. And I'm monitoring perfusion and things. We'll see where that goes. It's about to go to the next level of development for commercial. There are a lot of things that have been tried in the past, and I had a great time about 10 years ago going through the old literature. And I remember, some of us remember putting a silk suture between the 2 ends of the esophagus and letting it just sort of officialize together. There are then people put wires with little balls on the ends, and you pull the wire and push the other wire down. That's not so long ago. There's threaded wires with nuts. You have this wire which is sort of threaded, and you screw the 2 nuts on, and you push the 2 ends together. There's a guy in Japan who had actually reported good results around World War II with a big C-clamp. So you put the baby in a C-clamp, one in the mouth, one in the G-tube, and go cranking together every now and then. Lots of these kinds of variations. And some of them are still done. Haven't been fabulous results because these all require that you open the ends of the esophagus, so you're going to get some mediastinitis, and none of us like that possibility. And these mechanical variations, many of them, are all sort of unmonitored, so you don't know what kind of necrosis you're causing. There are still other techniques we can all try. Let's just wait.
Everything else is just wait. You get it. This is what I used to do when I was a younger pediatric surgeon. I just wait, hoping they're going to grow. And sometimes you go back in 3 months. It's not quite big enough. You go back another 3 months. Now it's close enough. You're going to try it. So the baby's growing, and sometimes the esophageal ends will get closer together. Sometimes they get farther together because when the baby's growing, the spine's growing as well. There's this, a lot of people, I think particularly in Canada, they like to do, where they shove bougies down the baby every couple of hours, going down the lower end and going upper end, and so you can get things together just by feeding. I've personally never had any success with this, and I think it's kind of torturing the child to keep shoving it down his throat. Certainly does not facilitate oral feeds in the future. All of these kids get terrible oral aversion. There's another option, which is to bolus feeds. So you hope you get a lot of reflux, and those children who have reflux across the lower esophagus, and not all of them do, then you'll get the feeds to go up into the esophagus, and that'll constantly get that to distend, and sometimes you'll get growth. There's been some experiments in nature where children had like pyloric stenosis, and they would get that to grow. We can develop all these other unidirectional balloons and hydraulic things are all growth factors. These are all in development. We'll have to see. We've talked about the Fokker process, which works. We make a little incision, and we put some sutures on, and we grow that. We talked about that a couple of days ago, the retraction, and over time, we can get this to the 2 ends now, which are pretty far apart, can be crossed, and we can sew them together. And at the same time, it's growing. You can see the volume of this esophagus is much, has much increased to 7 from 0.6 mL. And we've shown in animal models that it actually is growth. All the tissue layers are growing. And for long-term outcome, Dr. Fokker published his long-term outcome, which are actually quite good. So we have multiple options. We can use the Fokker process, and we'll have some strictures, maybe some leaks, dysmotility, and reflux. Colon has all of those, plus more problems. Gastric tube, all of these problems, plus these problems. And jejunum has essentially these problems, with very little reflux issue. So if you compare them, the Fokker can be done at birth. At the best, it gets 2 thoracotomies, and you're 3 to 4 weeks in the ICU. The colon, typically you want to wait about a year. Some of you may do it earlier, I'm not sure. It takes a thoracotomy, often a spit fish, so more surgery, less time in the ICU. Gastric tube, more surgery, less time in the ICU. And jejunum, 7 kilograms is my lower limit. I might go a little lower someday, so those bigger loops. And that's more surgery. But for the really long gaps, you need microvascular, and that's, you probably want to wait until 10 or 15 kilograms to do. The outcomes, we have strictures and leaks. G2 gastroscopy tube cells, the atrophic gastritis and the failure to thrive in pulmonary symptoms. I'm not a huge fan of gastric pull-ups. So, what are our options? Well, let's think about it from a resource side. There's lots of ways to approach this. From a resource side, it's the least resource is just wait. Let's just wait and see what happens. Sometimes it works. What's the price? Oral aversion, time in the hospital, then home. We can try bouchonage. Definitely cause oral aversion, shoving that tube down the kid's mouth every couple hours or days. Magnets, not very expensive. It's not FDA approved in the US. You can do it in Argentina. We can't do it in the US very easily yet. But we're working on it. The spit fistula with gastroscopy tube, and hopefully you get the lower end to grow. When you do a spit fistula, it's not going to get any longer. It stays where it is. You can lengthen them with myotomies and gastric pull-up. You can replace with one of these operations or do the Fokker process. Fokker process is the most resource intensive. You're using a lot of ICU bed time. So what's our goal? Remember our goal: preserve the child's health, understand the problem. We want to improve these disabilities. All of that is done without, and that's sort of standard of care. Minimize the risk of treatment, including brain development. So we want to avoid aspiration and hypoxia. And there is some concerns with longer ICU stays about the anesthetic influence and sedation influence on brain development. And we have several studies ongoing. Hopefully the next couple of years we'll be able to tell you about that. And we want to optimize the long-term outcome. And these all, the various techniques, all have to be considered. So how do we choose? How do we choose of all these options what we're going to do next? Well, we start with the patient's condition. If he's healthy, we have more options. If he's not healthy, then you have limited options. You're going to have to get the health back. How big is it? Depends on what we want to do. We have to consider size. If it's a premature infant, we're not going to do any of these. These 500 grams or 1,000 grams, you're going to wait no matter what. Then we have to look at what our local resources are. I mean, if we don't have an ICU bed or a hospital bed, you're stuck. Everything else stops. We have to look at what specialists we have. The more resource-intensive intervention we want to do, the more resources we need. That's equipment, that's OR nurses, that's anesthesiologists, that's intensivists, cardiac surgery for some of these things, microsurgery for the jejunum. We're talking about what experience do we have, and what preparation have we done in advance to make up for what experience we don't have. And we have to consider cost. I mean, I'm not lucky, I work in Boston. Cost is not a huge problem for people in Massachusetts who come to my hospital. If they're out of Massachusetts, it's a huge problem. And if they're coming from out of the country, it's an enormous hurdle to pay at the world's most expensive children's hospital. What are the parent expectations? These have to be sort of met, and they have to be sort of tuned. And what does society expect out of you? I mean, are you really going to get a productive member of society out of this child? And finally, what are the ethical considerations? You can't do, they're a little more liberal in Argentina for experimental stuff than they are in the US. We have lawyers who are constantly surfing like sharks for our blood. So what's the bottom line? All surgery is local. We know this. We just don't say it. We can only do what we can do based on what we're doing today in our institutions and with the resources we have. It's all local. It's like all politics. But for these kids, planning and preparation before a patient arrives, I think is pretty critical. Really putting the time and energy. We have to locally develop our resources and coordination. We have to get all this people and the equipment and the hospital rooms ready to do what we want to try to do. So that places the surgeon in an interesting role. You're not just a technician. You have to be the visionary. You have to be the leader of the team and develop all these other people to be working towards the common goal. You have to develop the skill sets in the nurses, and the OR, and the anesthesiologists, and you have to coordinate everybody when the time comes, and then you have to be the technician. So it puts the surgeon in a role that is much more complicated than just fixing hernias and fixing a little gastroschisis. If you're taking on these kinds of challenges, you have to be a superhuman being and do it all, like Dr. Fargo. So if you have any questions, I'd be happy to answer.